right. Cool. Yeah. So sure. You want to tell me the chief complaint?
Okay, so we have a 3-year-old female who's coming in due to increased work of breathing for 1 day.
Okay. So increase worker breathing for 1 day. Okay. All right. So I guess I'm always thinking differentials to start with, and then of course, oh, should I you know what I might do is actually to since it's on this thing, maybe I'll just share screen and I'll do a whiteboard it real quick. You can see the whiteboard, right? And I might just I don't know if this brings you back bad memories of you know of third year, but you know, hopefully not too bad, Okay. All right. Okay. In this situation, yeah, I'm trying to remember if we did do hot seat stuff. Okay. All right. So yeah, so of course we're reading, I'm always thinking respiratory stuff. And then you know, too old for bronchiolitis, so let's just take that out. Asthma is one, a viral upper respiratory infection is the other, along with its similar cousins of croup and COVID, of course, now, influenza. I will just put all the bad players there. You know, then, of course, the stuff that you hopefully won't see too much, hepatitis and some more of the vaccinated kinds of things, cystic fibrosis, and of course, the lungs and the heart are tied together. So I'm just going to go with, you know, some sort of heart disease or heart failure as well. Otherwise, I think, what else would give you sort of a quick shortness of breath? I guess it's a 3-year-old, so I'm going to think about some foreign body aspiration. Okay, cool. Well, we can, so yeah, I guess, then, yeah, we could definitely go on. Oh yeah, so I guess I'm just asking questions. All right, what you started 1 day ago? What was he doing when that happened?
Well, nothing much. Like things were kind of just like going usually, but then like the day before mom brought her to the hospital, she just noticed that like she was starting to get kind of wheezy and was breathing pretty fast, and looked like she was trying really hard to like get air in. Of note, she does have like reactive airway disease.
All right, and if you've ever been on my team, you know that's one of my all-time least favorite diagnoses. And the reason for that is because parents have no idea what it means, providers have no idea what it means, and in like parents are like, you know, and it's just confusing. So in my mind, to be honest, I always call it something, you know, bronchiolitis if they're young enough, and or you can do like viral induced wheezing, which just implies that, hey, every time you get a virus, you get a wheezing, or I call it asthma. And but by saying this, you know, like your airways are always reactive with, you know, asthma. But it's more because like if you call it that way, then parents know to say like, hey, my kid has asthma, and that's why we have an inhaler. So, but I get it. It's a gray area, and so people want to just call it that way. So, all right, okay. Well, hey, well, welcome Zachary. So we're in the middle of Brianna presenting a case to me right now. So welcome aboard. And let me see if yeah, okay, I like this. It's like East Coast representing right now, right? So you guys are like, we're gonna be East Coasters here. So okay, so yeah, so actually one thing that's gonna be helpful for your admissions is actually when you write your admission notes, a lot of people will say like yesterday on their admission note, but actually the helpful way to write it is the day prior to admission. And the reason for that is more like yesterday, you know, like can mean something different, and just more like when you do date of admission, 2 days prior to admission, day prior to admission, it gives people like, regardless of when they're reading your note, an idea of how to like do that. So, okay, so yes, has a history of reactive airway disease, and then sort of had starting wheezing breathing fast a day ago. Okay, so he's got some tachypnea. All right, and did mom try anything for the kid?
She gave her 3 treatments with albuterol and Symbicort overnight.
Okay. All right. Albuterol ×3 and Symbicort. You guys are like, what's Symbicort again? What is Symbicort? what is the generic name for Symbicort? You're like, oh.
That's a great question. I don't actually remember.
Is it a corticosteroid? I don't remember.
Like
Yeah,
B something. It's hard to pronounce. Yeah.
Yeah. So I think what's helpful is like the court, you're like, oh, it's a steroid. That's nice. The court portion tells you it's a steroid, but there's Pulmicort, which you should Pulmicort is the one that you really want to know in detail, and that's usually just budesonide. And what's super special about budesonide is it's actually like a nebulizer. It's like the only medication that is only inhaled corticosteroids that's nebulizable. The rest of them are all inhalers in a sense. And so this is why young kids will always have Pulmicort, because they're always going to be using like this portion. So that's just a helpful thing there. And then the fact that it's like together with something, it just tells you it has the long-acting beta agonist here. So the fact that actually the kid is actually already on Symbicort, what does that tell you?
Like, well, it's significant enough that they actually require some form of a steroid instead of just like your albuterol alone.
Yeah. They likely already have a diagnosis, a diagnosis of mild to moderate persistent asthma. Do you guys remember what if you have a question about asthma, what's the guideline you might go to? And you're like, oh, I don't remember. Yeah, and it's okay. I will.
I just remember the steps.
Oh, okay. Yeah, exactly. All right. So, clearly I can't share the screen with you guys right now, but I'll pull it is the best way to think about. Maybe I'll just create to decrease the trauma of you guys remembering third year stuff, or seeing this on third year. There's a reference thing I'm going to put here that it's called the asthma quick reference. And this is just 12 pages. It's like it's an absolute must read before residency, because it's what the steps are based on, right? Like the steps came out of this quick reference, and I don't want you to read a 488 page guideline, because no one's got time for that, not even a 4th-year med student. Okay, so yeah, so that just tells you actually this kid actually is serious enough so that like he's actually on a legit legit asthma medication this young. So that's what that tells me. Okay, so mom's tried that, it didn't help. Okay, and then so when you have an asthma diagnosis, because that's what you're going to zero in right now, like this is most likely asthma, you're like, okay, what are the triggers for asthma? So what are some of the triggers that people asked about in terms of asthma? What are like the things that people trigger asthma?
Like allergens, exercise, viruses.
Yes, viruses. Yes, viruses. So please respect us. Okay. Yeah. So like all the different allergens, exercise, viruses. So this is a huge one. So then it promotes you to say, okay, what are the actual? Did any of these happen? So is the kid recently sick?
Mom says she doesn't know of any sick contacts, and she hasn't really had any other symptoms like GI wise or urinary wise. And she's been eating and drinking okay.
Okay. Eating and drinking okay. So eating well or eating fine. Normal eating. Okay. Sure. Okay. So no other. So maybe not the viruses this time. Although like I guess it depends on the time of year. But right now everybody's getting. Well, I guess all the third years are getting COVID right now, and then a bunch of other people are getting viruses. Okay, so then exercise for a 3-year-old is a little bit on the harder side to say, hey, like they exercise, they're always exercise running around. Allergens, you might say, hey, like it might clue you into, do they take any other medications other than albuterol and Symbicort? Like if they're already on cetirizine, Zyrtec, like, or Claritin, what am I, loratadine, or Benadryl or something like that. Any other medications that this kid takes?
No, I think just the two that were mentioned is basically you take regularly.
Good. Okay, so that means that primary care doctor didn't think the kid had allergies beforehand, at least. Okay, so the kid is wheezing right now, breathing fast, and unsure if like he had multiple treatments. I mean, 3 times albuterol and Symbicort is a decent amount there. Okay, and then what prompted the mom to finally bring the kid in?
The treatments didn't help this time. And she was still, even after all that, continuing to have like worsening respiratory distress. So she brought her to the emergency department, initially at an outside hospital. So she was like a transfer, sort of.
Great. So what do you think outside? I mean, since you guys are going to be at, big academic medical centers, what do you think outside hospital will have already done for this kid?
Probably got some like basic labs.
Okay. Yeah.
Maybe just like threw some albuterol and steroids at her, because that's what most people tend to do in the context of respiratory distress.
Okay. Yeah, so they might use amino med nabs. What kind of steroids do you think they would have thrown at this kid?
Maybe like Decadron.
Yeah, that's the classic, some of the classic cocktail here. Now, if the kid was a little bit more serious, what else do you think they may have already tried?
They actually went like really extensively with her. They gave her
maybe we'll let Zachary sort of say, what do you think? What else do you think they did? Now that we know they did a lot, so what else would you anticipate?
So we already did the dexamethasone and albuterol nebs. You could, moving up the chain, you could do something like Heliox potentially. You could do, if we're like in status, you could do like magnesium as well. You can also epinephrine is coming to my mind right now. I think I'm on the wrong click there.
Okay. Yeah, no, I mean, you're throwing some stuff out there. Sometimes people throw them on oxygen already, but you're absolutely right. Like, yeah, Helix, mag sulfate, epi. The one that some people might still think about is terbutaline as well. But yeah, no, you guys are right on. The one other thing that you probably will notice is a lot of times people, like, especially when they're adult ERs, they're gonna throw, like, well, not because they're adult ERs, but like a lot of times they're gonna compare albuterol with another medication call it a duoneb. What is that? What's a duoneb? A duoneb.
Or like ipratropium, basically.
Yeah. So yeah, why am I thinking about it's a anticholinergic? No, it's a.
Yeah.
Okay, cool. So yeah, it's a llama. That's what I'm thinking. Long antimuscarinic. Yeah, I was like, what am I thinking here in a sense? So this is the duoneb. A lot of people will throw them on here, and they might put them on continuous albuterol too. They'll do Decadron. Why does everyone like Decadron over, like, prednisolone or prednisone or methylprednisolone? What's an advantage of dexamethasone?
With like the half-life, it doesn't. Yeah.
The longer half-life you can, and so like those other ones you're giving once or twice a day, or I mean like twice a day or every 6 hours, like a solumedrol is every 6 hours. This one like once a day, and people like it because you can give it IM if needed in addition to IV. So, all right. So okay, good. And all right. So yeah. Brianna, what did they do?
this was after much investigation because like her records actually didn't tell us like what medications they gave her, so we had to call and ask.
Yep.
Um,
Okay,
so,
who would you call and ask? How? Yeah, you're right. Oftentimes when you get these outside transfers, they come to you and you get like some random nursing note. It's not nothing on the nurses there, but it's just like the paperwork you get actually doesn't actually mean anything. So now you're like, I need to get more info. How would you get the info? Like, let's say you're literally in the ER with this kid right now, and like you have no idea what happened to the kid. The EMR report, I mean the AMR report doesn't show anything, and you're like, I sort of want to know what they got. And let's say you're back in the room trying to like piece together a story. Who might you call and talk with?
I think in this case we somehow managed to like contact their emergency department like directly, and then find whoever was involved with her care before the transfer.
Yeah. So actually, that's exactly who you call. You would actually call that emergency department, like look up their number online or whatever, and call the ED. And then there's two people you could talk with. One, you could say, "Hey, I'm the receiving doctor at this end. Can I speak to the physician who took care of blah blah blah?" And then they usually will overhead and like get that doctor to talk with you. Or you can say, "Can I just talk to the charge nurse?" And the charge nurse will actually have a good handle of like what happened with this kid. Like you might say, "Hey, what medications does this kid get?" Oftentimes by the time the kid gets to you, the ER doc is already off shift, and so the next ER doc might not know. But the charge nurse usually will be able to get you the info you need to really help you decide. So that's just a little random tip there. So okay, cool. What did they do? Yes, yes, you had to like call over, talk, and ask. What did they tell you?
So they gave her Pulmicort and Duoneb, and then they gave her prednisolone by mouth. They gave her racemic epinephrine a couple of times. And then they also gave her Decadron and mag sulfate. So they gave her literally everything.
Okay.
They were like, gosh.
Yeah. So which actually happens a decent amount with these kids. Because like, I mean, they come in sick looking and they're having a hard time breathing. You just throw stuff at them and you just keep on going at it. And all they're trying to do is stabilize the kids enough so they can get them over to you, right? Because this kid's in status right now. So, and yeah, I mean, right? Like it is still decently scary if they collapse on you. So, okay. To be absolutely honest, like, do you think there's anything else in terms of review systems that might matter here, or other histories that we would want to ask here? I mean, you're going to ask all of it, but like, trying to think, what could be pertinent here, if anything. Yeah, I would just ask the allergy portion, right? And just like if there's any allergies to that. Yeah, last thing you want is just like, oh yeah, actually you're allergic to, I don't know, print or something. So okay, okay, so let's say you've done all that. They're in the hospital now. I guess we can go on to actually, I do want to know about his physical exam portion. So vitals wise, 8 febrile and tachypnic. Blood pressure is okay. That sound about right?
Correct.
Okay. Sorry, guys. Okay, and then let's say growth chart, you don't have a whole lot, but the kid's just, like doing fine there. Okay, physical exam. Anything that you care about, Zach or Zachary?
Kids coming in with shortness of breath. I definitely want to right away listen to the lungs, see if there's good aeration through the lung fields. If there's any wheezing, if there is any lack of air movement, if there's any tugging, anything kind of like that.
Okay. Yeah. Okay, good. So I guess let's find out, Brianna, what does the physical exam show?
Okay, so on physical exam, she was like alert, interactive. She wasn't like, ill appearing or anything like that. Well hydrated, good cap refill. As far as like her respiratory status. She had like mild suprasternal retractions and tracheal tugging, some N expiratory wheezing, and subcostal retractions. And she was also using some accessory muscles for breathing. But otherwise pretty benign exam.
Good. Why do you, are you surprised by that exam, Zachary?
No, I feel like sometimes depending on how long this was, it 1 day ago.
Mm-hmm.
One day ago, I'm not surprised. Like it can take a while for the steroids to kick in and for the inflammation to go down. So I mean, I'm not really.
Okay, good. I mean, yeah. So I mean, initially when you told me this whole story here, I was also thinking, hey, is this kid in status? You know, in a sense, and yeah, you know, like I would imagine. I'll be honest, I always imagined the kid might look a lot sicker, but the kid did get hooked up with all this, and so maybe that temporarily is made things a little bit less. Because part of me is like, oh wow, we even heard some wheezing. Part of me sometimes like, do we even hear wheezing at all? Like I like how Zachary asked like, hey, I want to know about the air movement, and I will be honest, like you know maybe like 4 or 5 months ago, I had a kid come in and we ended up doing like a whole MIC workup and stuff like that. And we, you know, like I initially was told there's no wheezing, and I went to listen to him. And I didn't hear any wheezing, but then I was like, wait a second, he doesn't have wheezing because he's not moving air. And the kid actually just had an asthma exacerbation after I threw the kitchen sink at him. So, but yeah, so air movement is huge in addition to wheezing here. But yeah, so okay. Right, if not moving air, you're not gonna have wheezing. So we talked about retractions, that's good. Really, like the rest of the exam is not gonna be super important to me here either, in a sense. But yeah, you said he's perfusing well, which is another thing that making me okay. He's not gonna be having impending cardiac stuff or whatever. Okay, so workup wise, the outside hospital, they probably got a chest X-ray, although we don't necessarily need to get one, right, in a sense. But what did that show?
It was normal.
Yeah, normal. Okay. Yeah, and then I'll be honest, like I would, you know, when they send you outside X-ray reads, I always say, it's an adult radiologist reading a pediatric X-ray here, so I'm always a little bit like, you know, like, okay, if I have any question, I can always show the image to my my pediatric radiology people here. You can call down the radiologists, hey, can you review this quick image with me? Oftentimes they don't they come with a CD, so you have to upload it yourself. So that's a quick intern skill I would pick up, because something just like whichever hospital you're at. Zachary, do you know if VCU is going to end up having Epic, or is it something else?
It's Epic.
Okay, all right, cool. So yeah, so Epic's integration with some stuff is a little bit better now, so you might be able to pull up a lot of. I can look at a lot more imaging now as an attending than I could when I was a resident, because of like how integrated things are. So, but here you might just say, I'm gonna look it up myself and go like, how many ribs are there, and then be able to check if there's, you know, like they might say normal, but you might actually look at it and say he's hyper expanded. They just are more commenting on opacities or not. So, but we didn't expect any opacities in this kid because of just his history, right? Now, if he came in with like fevers, cough, sore throat, and then wheezing, and he's been going on for 2 weeks, then I might, okay, the chest X-ray could show pneumonia there too. But sorry guys, I'm actually obviously recovering from COVID from last week, so just coughing away here. Okay, so do you think, you know, like I don't imagine the CBC. What do you think the CBC is going to show, Zachary? Sorry, Brianna obviously knows the whole case, so I mean, asking you.
You might have like a little reactive leukocytosis, but I think other than that, within normal limits.
Okay, yes, that's exactly what I would anticipate, especially reactive from the stress or reactive because they got steroids. So either way, so usually it'll be up a little bit, and then the CMP won't really show a whole lot either. Is this what the kid came to you with?
Yeah, so they had a white count of 18. Their CMP was normal. They got a ProCal that was also normal. They did an RBP as well.
Okay. Yeah, actually,
give everything, but
yeah. It's gonna give away the virus. Is that what you're saying?
Gonna give away all the viruses, which is like it was January. When was this? Like February. Like
Uh-huh.
everybody had a virus, so
Uh-huh.
surprisingly,
Okay. So before you say the virus, what virus do you think it was, Zachary?
Yeah. This is here in January.
Mm-hmm.
Um, I mean, I can throw maybe like an RSV out there, or maybe like a, let me think.
Well, what is the most common virus you've been seeing? Even more common than RSV.
Or you're not referring to COVID, but
Nope. Oh yeah, yeah, yeah. I mean, no,
okay.
I mean, could too. The kid could totally have. I mean, it's January. Yes, totally could have COVID. Yes, absolutely. But even more common than COVID, actually. Maybe not in January this year, but like in general, what is
Like
the most common cold virus?
just rhinovirus in
Yeah,
general.
it's rhinoentero. And so yeah, you're gonna see this like literally maybe half of all the cases I will see this, if not more in a sense. So, but you're right. Like now they put all three out there, maybe the way Brianna was talking was like maybe there are two viruses on here. Um, so what did the RVP show?
she is rhino and tarot positive and COVID-19 positive.
Oh,
Okay, there you go. Yeah. Hey, look at that. I wasn't even thinking COVID, but so Zachary was right on there in terms of thinking that. So good. All right. So yes, so the kid has both of these, and you're like, huh. All right. So now that the RVP comes back, and so like on your test, you're never gonna get tested on RVP, but in reality, like I will be honest, like I think most people move towards just ordering it. And that's okay. For me, like I think I learned a lot by this and just helped me sort of get an idea of like the prevalence of a lot of these viruses, trying to get an idea of like the severity, especially if you're trying to distinguish between COVID now and not. All the RVPs have it. And then yeah, and then it also gives me just a little bit more like RSV, tells me okay, like maybe it might be a little bit more severe than rhinoentero. And then if it says human metapneumovirus or just metapneumovirus, then it's probably the most severe out of all of them, other than COVID and flu, of course. So that's just sort of like for me, like I just maybe add an extra day or two in my mind when I think metapneumovirus if it hits a kid enough that they're requiring oxygen. Oh yeah, by the way, what was the O2 stats for this kid? That probably was abnormal or lower.
When she was with us,
Mm-hmm.
let's see. She was like 95 on like the liter.
Good. All right. So treatment wise, you can imagine she got admitted to the ICU because she got hit with a lot of stuff. Is that correct? Was she on continuous albuterol
Um,
or not?
actually, like she was pretty like after all of that she got at like the outside hospital. Once she like got to us, like she was pretty stable, and like they were actually able to bring her down to like half a liter. So she went to basic.
Okay. There you go. Okay. Well then, yeah, she's half a liter. And then yeah, then she's just on like albuterol, like the albuterol pathway. Obviously, your new hospitals won't have. They'll have their own like version of something like that, but essentially just wean her off, or wean down the albuterol. Do you need to give her anything else other than albuterol right now?
We just basically gave her like oxygen, albuterol, and then put Tylenol on in case she had a fever. And then we ended up giving her, I think, a second dose of Decadron like the next day after she was admitted, just to like cover all the bases since she was still having a little bit of wheezing.
Okay. Yeah, actually, yeah. I mean, clearly I was just thinking up here on my mind, but absolutely she needs steroids. What am I thinking? So good. So you can imagine, like, I mean, even as I make that mistake right there, you can go like, it's very easy to remember, like, miss a detail here or there. So Decadron ×1 again. So she's got 2 days of Decadron, which a lot of places say are equivalent to 5 days of like, prednisolone or something like that. Now, you can, one of the studies you might look at, like, I don't think it's a top 20 most important article, but it's like actually those studies are mostly in the ER. So if you get 2 doses of Decadron, it's sort of like equivalent to 5 days of steroids, but only for ER patients. When you get admitted to the hospital, there's not good data saying Decadron is superior to like prednisolone for 5 days. So just something to throw out there. But one thing that might be an example of you like seeing you're like in your mind, like I was always trying to prednisone for 5 days, and I'm seeing a bunch of people here just give Decadron. Like, and so you're like, should I just start doing Decadron for everyone, or should I just look up the data and say, oh, actually, Decadron might not be like, it's not the best, but maybe it's not the worst either, and stuff. So that's how you might change your practice. Even if you see somebody else do it differently, you should always go for yourself. Especially when it conflicts with what you've known for in the past, like it just makes you want to look it up a little bit more and just try to go like, So, okay. So yeah, so she gets some Decadron. All right. So now you're getting ready to send the kid home. What would be some discharge instructions that you would give this kid?
The anticipatory guidance is always very I guess like essentially they usually get like asthma education. I think it's really important because she's never had the formal diagnosis of asthma, so her mom wasn't really like fully aware of what that all entails. So we essentially like diagnosed her with like mild persistent asthma, more or less. And so this is what this is going to look like. And make sure to follow up with like your primary doctor and like look out for, again, return of like increased work of breathing or wheezing, or if she's not improving after giving like her normal medications or fevers, basically like that sort of thing, or she's turning blue, that kind of stuff. Yeah.
Did you send her home with any medications? And how should you use them?
I'm like, this is a really long time ago. I think we just basically with like the albuterol and the Symbicort, more or less, we told her to just keep taking those. And I think maybe like some Tylenol just in case.
Good. Yeah. So maybe the albuterol here, like whenever I discharge them from the hospital, like they obviously going to start moving towards PRN, but at the end of the hospitalization, they still probably have a couple days where their airways are sort of like still, hyper reactive a little bit. So actually, I have them just do albuterol for every 4 hours for the next few days, just to like sort of taper off, and then they can go PRN, right? And then the Symbicort you're going to continue as well. So, all right. So now, how would you, like, would you send this kid home with a nebulizer? Let's say they didn't have one. Would you send a kid home with a nebulizer or inhaler with a spacer?
I would send this kid home with an inhaler and a spacer.
Okay, tell me more, Zachary.
So I was actually just reading the study. There's several studies out there that show like the efficacy of properly used inhaler and spacer versus nebulization with albuterol. And I think it's really good. Like one of the first things on the discharge list was the asthma education. So like showing parents specifically how to shake up the albuterol, how to have the child like seal their lips around the spacer, and how studies have shown that it's equally efficacious to a nebulization, if not decreasing hospital length of stay as well. That's at least one study that I had read before. And also like nebulizers, like you have to like, they're bulky, they're big. You can take like a spacer and inhaler anywhere with you. So like who knows, like maybe, who knows what the trigger for, I mean, it was Rhino and and COVID, but I mean, maybe if like, maybe they're using the spacer incorrectly and, like it could have potentially, prevented hospitalization or something like that.
Okay, good. So in this situation, you're like, that's sort of, yeah. I think that sells it pretty well there. And then yeah, like if you've never sort of like seen exactly how to do the albedo inhaler, I think that's worth watching at least once in terms of like with a spacer and how long they're supposed to hold things in for. But yes, I always try to sell it more like, do you really want to walk around with this bulky thing that you have to plug in wherever you go? Like, do you
Sure.
like having a huge diaper bag with like everything in there? Like things like that that make parents like, actually I hate that, like, or like, like, yeah, what if you're out and about? And so you're like, oh, hey, look at this two small little things, and it's just so much easier. And like you don't have to wait for case management to get the nebulizer, like you don't so it's just like I think exactly like the way you just said, hey, like the evidence actually shows this is actually more effective and it's easier. Like it's a double win. And so when you sell it like that, then most parents like, I would say 80 to 90% say, okay, just do the spacer. The other ones just like, are just like, no, but the nebulizer works better. And you're like, actually it doesn't, but it just looks cooler, and that's why people will go for it. So it's like, but then you might also say, hey, you did try the nebulizer 3 times and it didn't work. So it's like, okay, like we want you to have a spacer inhaler. So and yeah, at this age, so in my mind, after 2, that's when I start transitioning off the nebulizer. Before 2, like, yeah, okay, they're not gonna be able to follow the instructions as
Yeah.
well. But yeah, so 2 to 4, I usually, like if they really want the nebulizer, fine. But like after 4, I just like say, what are you doing? No, don't do that. So yeah. All right. Cool. Well, okay. So yeah, I know we just sort of walked through a case here, but this is a super classic case, right? Like maybe this is the top 5 of all kind of cases you're going to admit during residency. And now you feel a lot more comfortable with, like, and the cool part is like, you'll notice I was just commenting on a bunch of stuff. All that commenting there is just like more like patterns after a while. When you do enough of these, you like start seeing some of those patterns and stuff. So now I'm going to actually move on to actually, yes, it's still here. Okay. I'm going to share screen with, all right. So you can see the Epic screen here, right? So this is the Epic Playground, which means that these are not real patients. Clearly, Jake's old master is not a real patient, but we're going to pull them up here real quick. And I apologize if you really don't end up with Epic at Penn State.
So I looked it up. They use Cerner. So
oh, okay.
sadly, no.
Yeah. Well, I did my intern year on Cerner. It was painful. I'm sorry. It's probably way better now, by the way. But it is something to you can. I'm sure they will. Yeah, you'll work it out. It'll be okay. All right. So in this situation, let's say you're in the ER. You've just seen this patient, and you just got all that history. You called the ER doc. You're now back upstairs. You're putting in the admit orders. How would you put the admit orders in here?
I'm gonna be honest and say I did not actually do this part
Yeah,
of
that's
the
okay. Yeah, no, oh yeah, no, we're just practicing so that you
Okay.
get a workflow of like, because in residency everything will be so fast paced that they're gonna say, hey, like, like try to do this and that. So you might want to go back upstairs and start writing your note, but you're not allowed to do that because you have to get the kid admitted and get the kid moving. So before you write your note, you're gonna write admit orders, and so you're gonna go to admit. There's an admit orders tab here. Okay. And what is part of the admit orders is going to be actually, you'll notice, is they're going to review the current orders. Whatever they already have ordered in the ER is going to be here. Okay. So oftentimes you can just do continues unselected or something like that. It just pulls it all over. I mean, if the ER has orders, just continue them for right now. That's the simplest thing in my mind instead of like trying to mess around with stuff, right? The next part of the admit orders portion is actually going to be a med rec. This is actually why during your admission, you're going to actually go through every single medication that they have. The ER doesn't necessarily do this because they don't have time for it, but you have the time to ask every single medication, and you need to get the exact doses and how they take them and how often. Most of the time, like, or half the time, parents won't really know, but like you're going to push them as best you can. You're going to say, okay, you may not know right now, but I definitely want, somebody at home to give you a call with the bottles or whatever it takes to get it accurate. Because if okay, let's say you want to, let's say, you know, you want to like, mark all these as accurate and just sort of go from there. Because not only are you going to review the home meds, this is the part where you reconcile the home meds. What does reconcile mean? It just means like which ones are you going to carry forward in the hospital? Okay. So, right. So you literally are starting them on stuff based on what they are telling you right now. And, of course and they might do all these extra things. You're like, okay, whatever. So it's going to be all this different thing. And this one's more for Zach. Do you know how to get out of the screen really fast here? You just right click.
Okay.
Yeah, the right click is probably the #1 tip saving thing in Epic. Like, so, like here, because otherwise you're going to ordering this and it's going to pull up all this stuff and you're going to like try to find it and this and that. And you want to click accept, or it's just easier to right click. So
Didn't know that.
yeah, I know. You're like, oh, that's so nice. So once you order, these are orders you're putting in, right? And like, so as soon as you order those, then like clearly when they get to the floor, the nurse is going to start giving some of these medications there. Okay. Next up is your order set here. This is like, a lot of places will have something called a patient placement orders. This is sort of where you're going to like open an order set, is just like all these like preset kind of orders. So you can click away, but you're going to admit from the ER to inpatient, and then it's going to make you pull up all these here real quick. They're going to always ask you a DNR status. In pediatrics, obviously it's going to be a temp resuscitation, and like all the time, unless there's something different, right? So okay. And yeah, sometimes there's just like annoying stops and stuff like that, but it is what it is. So okay, you're always going to order isolation. What kind of isolation would you order for this kid?
Airborne.
Yeah, you might do airborne if you're thinking TB, but actually since the kid has COVID, you just put COVID. Cool. And any other virus, if you're not sure about the virus, hospital epidemiology has a list of all the viruses and what kind of ISO they require. If you're not sure at the first, I always just do contact and droplet. I guess maybe these days it might be contact and airborne because of COVID or something like that. So, okay. So this is just how you sort of do, they're always gonna, especially in pediatrics, they're always gonna ask you isolation status, and you have to be able to determine that. All right, then you're actually ordering all your vital signs, how often you want them, whether you want neuro checks on this kid? No, don't. Yeah, the nurses will be like, can you just take that off? Because like, what are we doing here? But vitals, pulse ox, sure. Prior respiratory monitor, sure. And then some of this stuff. Okay, so if you do want to put additional orders in, this is where you type in stuff. I want to do a CBC with diff or something like that. You can type that in here and order stuff and blah blah blah. Right. So this is sort of like, these are all the different things you order. So this whole process, you want to be able to do this relatively quickly once you get upstairs, because the kid cannot move out of the ER until the admin orders are in. So the tough part here is you're like, oh, but I haven't thought about like whether I want to order Decadron or not, or all the other stuff. And so this is where you're just like, if you're able to order it quickly and you know what you want to do, this is where you might do some stuff. So here, so as you're putting admin orders in, you might just throw in the admin orders in and then talk to your senior resident and say, hey, this is why I ordered for this kid. Anything else I'm missing? Oh yeah, did you order the albuterol? Oh yeah, I totally forgot that. And then you put that in or something. So, but that's how you might go about it quickly here. Okay, so once you're done with that, you sign away, and like obviously it's gonna make me do all these things, but it's just sign and hold, and that means that until they get upstairs, like the nurses downstairs can release some of the orders, but like when they get to unit, they're gonna like start doing all this stuff. Okay, so that's your first thing is admin orders. Like that's what they really want. Sometimes they might use the term like skeleton admin orders. They just want something to get the kid moving, because the ER needs to their priority is to move patients, right? So, okay, then you might go, okay, well, maybe this is the time where maybe I can start writing some of my note here. You know, depending on how you do admissions, some people might just take a workstation on wheel downstairs and I just type like a note while I'm talking to the patient. Some people write on a sheet of paper and then like write a note on it. However you want to do it and use your workflow is best, but like just that's just something to note there. So create a note, do your whole thing here. And then when you're done with your note and your admit orders, you're done with the admission. But so at first in residency, it's gonna take you about like, I don't know, 2.5, 3 hours to do some of this sometimes. From like getting the call on the patient, going downstairs, asking all the questions, maybe calling the outside ER, coming back upstairs, writing the admit order, writing the note, like coming up with your assessment plan. It can take a while, but you do want to like start to push to get it closer to maybe like hour to hour and a half, like, by the end of your intern year for an admit, for admissions. I don't know. I'm the slowest person I know. So, maybe there's a really long time period, but like I'm very thorough and detail oriented. And sometimes what's tough is you might start working on your note, but then boom, the next admission comes in. What do you do in that situation?
I'm a person to take notes, so I would already have another note, or I would already have something else written down. I would just probably have to go to the next admit, I guess.
Okay.
Yeah.
Yeah. You might say like, I'm still working on this note right here. Like, do you need me to go down right away? It's a legit question to ask that. Or like, maybe like 15 more minutes on the note. Would you prefer me just to finish this off and then you can review my note while I go see this new kid? Because you're still going to be working your senior, right? They're still going to be working with you. Or they might say, hey, we're like 10 deep now in terms of missions. Just get going on the next one. You'll write the note later. As long as you get the orders in, that's what matters, right? Because the note's really for you, to have, as long as the note's done by the time you hand it off to the resident in the morning, that's what matters. But the orders, you have to like be able to, like have in first. So, okay. So that's the part that's, I think, toughest, because I always wanted to have my note done, then write the admit orders, but you can't do that. So,
I have a quick question.
sure,
So
of course.
once you place these admit orders, the patient is officially like on like acute care service. So even if they're sitting down in the ER, that's our patient. So like they're not being assessed by any physician down in the ER anymore. Like if something like the child like crumps, is it us who is going to be called down, or is it the ER physician downstairs?
Yeah, I mean, ER physician, while they're still physically in the unit, will still like keep a random eye on it. But oftentimes, what happens is, yeah, when they on their end, they're gonna see a little dot saying, "Hey, like this person is like admitted." Like they're gonna like most of the time they'll just shut their mind off because they got so many other things going on, like they're on their way. But if the kid starts to like go into the stats into the 70s, the ER docs, like the nurses can call the ER doc to come over right away. Now, if the nurse is like looking at the order and the decadron dose looks really high, she's going to page, or he or she, sorry, is going to page you because you're the physician on that case now, and you're like, okay, well, I'll correct that portion. So that's how that part might work. Every ER is a little bit different in terms of like how much responsibility they want or don't want once you're admitted, but technically, for all intents and purposes, once you write the admit order, they're your patient.
Okay.
Cool. So yeah, there's the orders portion here. And the last portion I'm going to do here is just actually the discharge, since we did get to that point where we're going to discharge this kiddo, right? So there's a discharge tab here, and discard orders, whatever. Okay, so how the discharge works that you might consider is, so you'll notice like actually what's interesting is there is, on this side, they're gonna actually have all their home medications here. So the reason why the initial medrac is so important is because right here, you're gonna continue to take these meds or don't continue to take these meds, regardless of whether you have them do it in the hospital, right? So you're actually gonna so you could, if you don't get the medications right at the start, you're gonna continue the wrong medications, they're gonna go home with the wrong medications. So that's an important portion there. Now, there's also going to be medications you start in the hospital. Let's say we start albuterol in the hospital, or dexamethasone or something like that. And this is where you can start adding it or just saying, hey, just stop it and stuff like that. Now, it's one thing to continue a medication. It's another thing to prescribe and order a medication, right? So so the part of it is knowing what the parent needs, right? Like, most of the parents have all the medications at home that they need. They don't need all brand new prescriptions for every single medication they're on. They just need brand new prescriptions for the medications that you prescribed in the hospital that they don't have at home. So that's where you're going to start, prescribing some of these things or something like that, right? And this order set's going to look a little different. It's a pharmacy, the whole thing. You have to put refills and quantity amount, and this is where you're like, put in stuff. Sometimes there's common sizes down here that helps you out. So you might go, oh, okay, that's what you do. So, okay. So that's that's why the med rec is important for not only admission, but on discharge, it's going to be huge to make sure the kid goes home with the right medications. And this is where I see plenty of mistakes being made. And a lot of parents are confused. They're like, you told me to this or that, and just, yeah. So, so then there's that portion. And then there's the actual just like discharge orders and stuff like that. Discharge a patient, where you're sending them home to, time wise, DCL their lines, start their medications, let me just put like 20 each, 5, and then stop taking something and sign off. Okay, once you sign this, they're technically discharged, and that's that. Now, if you notice how many pop-ups were there, that's exactly what happens to every intern. It is really annoying after a while. So you just got to get quick at reading those and just like clicking, knowing which ones actually matter and which ones don't, and that's it. All right, so you just did a case presentation there. You admitted a patient and with admit orders, and now you've discharged, and hopefully now you feel like, okay, this is what a pretty standard kind of workflow is for some of your patients in the hospital. Any questions?
I do have a question. And it's not specifically related to the process, but I remember you talking about it a while ago, Dr. Wei, and it's the topic of, or the question of cardiorespiratory monitoring versus telemetry. Can you distinguish those two once more?
Yeah, no, and that's the thing you saw on the admit orders. There was cardiorespiratory monitoring. Cardiorespiratory monitoring is the three things, like the three little like buttons that you see here, and one on your lower, and that's sort of more like that's really just so they can put it on the monitor next to the screen. You're going to see a lead 2 up there. You're going to see the heart rate. You're going to see one rhythm strip thing up there, and then the O2 sats, and then the blood pressure. That's cardiorespiratory monitoring. It means that just like one lead is going, just lead 2, and nobody's looking at that except whoever's at bedside looking up at the monitor. That's cardiorespiratory monitoring. Now, sometimes that also includes a pulse oximeter and stuff like that. Now, telemetry is they have all 12 leads on, and then they have a little box that they're carrying here, and it's automatically transmitted over to the telemetry nurse station, and the telemetry nurse there is watching they're looking at, they can look at any of the 12 leads going on at any time, but someone's always constantly watching that one. So you can see it's a higher level of care. Oftentimes telemetry is not, you're not allowed to do telemetry on the basic floors. It's oftentimes on step down units and ICU units. So, so in this kid, would you want cardiorespiratory monitoring or telemetry?
Cardiorespiratory monitoring.
Okay, cardiorespiratory monitoring. Now, if the kid came in and his heart rate was like 180 and he was having palpitations, and like he's got a history of cardiac stuff, you might say, oh, let's put him on telemetry, and that's okay, because you don't want him to start doing something even weirder if you hit him with more albuterol or something like that.
Right, for sure. Cool. Well,
thank you so much. But then that would make you go like, oh, this kid now can't go on the basic, he has to go step down. Okay, that's fair. I mean, I'm spooked out enough, like 3-year-olds at 180 and like with a heart disease problem, right? So like, okay, that's fine. But there's something that's a negotiation with the charge nurse, and you do have to be able to explain. Charge nurse be like, why is this kid coming to us? And you're just like, I'm concerned enough to put him on telemetry because of this, and that. And they're like, oh yeah, that makes sense. So, but,
got it. Thank you.
Yeah, cool.